Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. Tonight, we're going to be focusing on what's new with back pain. My guest this evening is Dr. Grace Ahn, a rheumatologist practicing here in Montgomery County. Dr. Ahn, welcome to Housecall.
Thank you. Thank you for having me.
So briefly tell our viewers, before we proceed with the discussion, about your professional background.
Sure. I did my undergraduate studying music and biology in University of Virginia, and I got my medical degree at Virginia Commonwealth University School of Medicine. I did my intern year at Drexel Hahnemann University in Philadelphia, and then did my rest of residency and fellowship in Chicago at Northwestern. I practiced in Baltimore for about 2 years until I joined arthritis and rheumatism in 2015.
Terrific. And you practice here in Montgomery County?
Yes.
So the topic we're going to be focusing on tonight, low back pain, is a major topic, a topic that many of our viewers are interested in. So briefly, give our viewers a sense, how common is low back pain in our community?
So back pain is one of the most common complaints that patients seek medical care for. It's approximately about 10 to 20% of U.S. population have thought to have some kind of neck pain or back pain at any one moment. And up to 84–85% of individuals will have back pain at some time in their lifetime. So it's one of the most common problems that you end up talking to your doctor for. And I think that's why it's kind of important to discuss it today.
What are some of the structures? Acquaint our viewers with some of the anatomy that play into developing low back pain.
Sure. So the back is made out of many different structures, not only the bones. So we call these vertebrae that makes up the bony spine of our back. There are different areas of the vertebrae. We have the cervical spine, which is behind your neck. We have thoracic spine, which is behind, in the upper back, and the lumbar spine, which is the lower back. So vertebrae are the bones that make up the spine process. And then there are discs. So these are shock absorbers or cushions that is in between the vertebrae, and that helps support the back. And then there are different nerves that travel actually in the spinal column, and it helps to innervate the rest of your body. On top of that, there are ligaments or muscles that also supports the back. So there are many different structures that kind of make up and can cause problems if someone has a back pain.
So given the complexity of the anatomy, as you've described it for our viewers, what are some of the causes then of chronic back pain?
So there are numerous causes of back pain. We like to typically divide these into mechanical causes and non-mechanical causes. So mechanical causes can be a structural problem where someone can have an injury, wear and tear issues, trauma, or even...
What do you mean by trauma?
Trauma causing injury to the muscles or the bones. Or you can also have physical abnormality from a structure. And these are, I would say, more common than non-mechanical causes. And because it's a structural abnormality, patients can have worsening of the back pain from a certain physical activity and perhaps improvement by others. For example, if someone has spinal stenosis, which I'm going to talk to you about in a little bit, they can have worsening pain when they are putting more weight on their spine, so walking, things like that. But when they flex their spine or bend, they may feel a little relief because of the structure that's wrong with them. Majority of these mechanical back pain do resolve on its own if it's acute, but a lot of them can recur over time, and about 10% of these back pain patients can have a prolonged course more than a year. So it's a serious problem. One of the most common reasons for mechanical back pain includes muscular strain, meaning that you are stressing or straining your muscles by doing certain movements. Let's say someone's picking up something in an unusual position, and your muscles couldn't support you, and all of a sudden you have pain. You can also have wear and tear arthritis in your back. We call these osteoarthritis or degenerative arthritis that can happen in your back, and it typically happens in older individual, but if someone is an athlete and had a recurrent trauma to the back, for example, they can develop osteoarthritis early and can have back pain. Another common mechanical cause is herniated disc. So you may heard of this a lot. Like I mentioned, discs are shock absorbers or cushions. We like to think of it as like a jelly donut. If the jelly gets stress and doesn't stay in the donut, it can spill out and cause, for example, pinching of the nerve that goes by them, and end up causing discomfort that way. So that's one common mechanical cause. And another one that we often think about is spinal stenosis. So I told you a little bit about spinal stenosis example earlier, but spinal cord, so group of nerves that travel in your back, can be irritated by different structures that goes in between the nerve and the bony area. That could be big bone spur or osteophyte from osteoarthritis, or it could be the herniated disc we talked about. So these are common causes of mechanical back pain. The other things that we often don't think about right away is scoliosis. So people with a lateral curvature of the spine that worsens over time, that can also cause back pain. And there's another one that's very hard to pronounce, but spondylolisthesis. It means that a vertebrae bone can be displaced in relationship to the bone underneath, and that can cause pinching of the nerve that moves by. So these are common mechanical causes. And then there are non-mechanical causes. These can be systemic disorders that can affect your back. So for example, someone can have cancer, let it be breast cancer, lung cancer, thyroid cancer, that can spread to the back and not know about it, and that can cause your back pain. You can have infections that can go to your back and cause abscesses, which are pockets of infection that can cause back pain. And then there are different inflammatory disorders, such as psoriatic arthritis or ankylosing spondylitis. These are autoimmune diseases that can cause back problems separately. So there are many, many causes, and certainly there are common ones as well as atypical ones, but it's important to kind of pay attention and talk to your doctor about it more.
We hear a lot about osteoporosis, thinning of the bones involving the spine. Can that cause back pain?
Yes, so that's one thing I left off, Dr. Doman, so thank you for reminding me. So osteoporosis means that your bones have thinned. So this happens over time as people age, or for women, especially postmenopausal women, the protective effect of estrogen decreases, and then you start losing a lot of bone density. With traumas, even light traumas such as bending or coughing, in those patients with osteoporosis can cause fracture in your back, and we call these compression fractures, and that can certainly cause back pain.
Yeah. So I would imagine many of our viewers over the years have experienced some transient back pain. For example, a weekend golfer may come back from a round of golf, or a tennis player, or something of that nature. So when should a viewer who experiences back pain decide this is more than just transient back pain? When should they seek the services of a rheumatologist?
So that's a very good question. A lot of times, majority of these acute nature of back pain sometimes self-resolve, meaning they get better on its own. If there are certain things like severity of the back pain is worse, or you're having some neurologic symptoms like a sudden weakness or unusual numbness, tingling, or you're dropping your foot or something, those kind of unusual symptoms, I would say you should seek your care right away. To see a rheumatologist, we do take care of all kinds of back pain, including the mechanical ones we talked about, but we especially do take care of all the autoimmune diseases as well. So,
would you define autoimmune for our viewers,
right,
please?
so autoimmune disease means that your body, so you have normally healthy cells that fight off infection or fight off inflammation. There are certain individuals with these autoimmune diseases where your immune system doesn't act normal and may cause actually more harm. So your own cells are causing some inflammation or damages to your body due to a certain disease, for example. So we do take care of inflammatory conditions. So I mentioned psoriatic arthritis or ankylosing spondylitis briefly. These are one of our spondyloarthritis, so specifically autoimmune diseases that affect our back or other joints of the body that happens because of inflammation. And they may have other clues like psoriasis. They may also have different diseases like inflammatory bowel disease, ulcerative colitis or Crohn's disease, or they may have an unusual infection that led to an inflammatory arthritis episode. And these patients present a little differently. They have a little more severe symptom. They may have stiffness that lasts for many hours in the morning when they wake up. They usually don't feel better when they rest. They feel better when they move around. They might be younger than what you would expect for someone to have a back pain. So for these conditions, the treatment is a little different, and rheumatologists treat them normally. So I would say in those cases, you should seek care of rheumatologists right away.
Now you mentioned treatment. We only have 2 minutes left.
Okay.
But very briefly for our viewers, what are some of the treatment options available for low back pain?
So low back pain depends on the cause in terms of how we focus on your particular treatment. But if there are modifiable risk factors, so if they're very morbidly obese, or they're a smoker, or they do certain kind of physical activity that exacerbate the back pain, then we ask them to work on those. We also use guided physical therapy or certain exercises, including core strengthening exercises that can help your back. In certain instances, we use anti-inflammatory medications, muscle relaxer medication, sometimes pain medications. Some patients get, we recommend getting steroid injection to your back, or in certain bad structural cases, we say, hey, I think we may have to get you to be seen by a surgeon. So it's a multidisciplinary approach in terms of trying to treat a back pain.
Okay. We are unfortunately out of time. If our viewers have any questions about low back pain management or rheumatology in general, how can they reach you?
So they can go to our website, www.washingtonarthritis.com, or they can call our office at 301-942-7600.
Dr. An, thank you for joining us on Housecall.
Thank you.
We're going to pause briefly for a public service announcement. When we return, my next guest will be Dr. Jeffrey Potter, a rheumatologist, to discuss gout. We'll be right back.
If you want to be a parent, it doesn't matter how you play or even what you wear. You just need to be there. Thousands of teens in foster care don't need perfection. They just need you.
We're back. My next guest is Dr. Jeffrey Potter, a rheumatologist practicing here in Montgomery County. Dr. Potter, welcome to Housecall.
David, thanks so much for having me. Appreciate it.
My pleasure. So briefly tell our viewers about your professional background.
Oh, absolutely. So I'm actually a native near Washingtonian. I'm from just outside of here in Fort Washington, Maryland. I grew up in Southern Maryland. Spent my undergraduate years in New York before coming back home to my graduate studies at Howard University. Spent my time there doing my postgraduate work there as well during internship and residency, and then again traveled to New York to do some my fellowship work. Spent about 3 years on faculty at University of Virginia with the rheumatology department there before coming back to home in March of this year. So I've been with Arthritis and Rheumatism Associates for about 9-10 months now.
Congratulations.
Hey, thank you. Thank you. Good to be here.
So we're going to discuss in the second segment now gout.
Yeah.
Explain to our viewers what exactly is gout.
Absolutely. So gout is the most common inflammatory arthritis that we see as rheumatologists. And the distinction between inflammation types of arthritis, which cause pain and redness and swelling, versus wear and tear arthritis, which cause a bit less of that, is one that we try to make pretty distinctly when we're evaluating patients. Gout tends to be a very exquisitely painful, very rapid onset of symptoms. Patients will describe redness, swelling, discomfort, inability to move comfortably or ambulate comfortably. At times, gout can be so painful that patients aren't able to wear shoes or socks or even have sheets touching their feet if that happens to be their affected joint. Gout can present in any joint whatsoever in the body. The toes are most commonly affected, but knees and ankles and wrists and elbows can also be affected as well.
So what are some of the signs and symptoms of gout?
So what we tend to look for in our evaluation of patients is swollen joints, angry looking joints, red joints, joints that are stiff, and patients are having difficulty moving around, difficulty ambulating. Very often in times with patients with gout, there'll be a trigger. There'll be something that we can identify that's actually caused some of these symptoms to become to bear. And that's also part of our questioning when we're sitting down with patients who we have some of these signs of symptoms. But largely it's a disease characterized by inflammation. So redness, swelling, and warmth are the things that we look for most commonly.
And what exactly causes gout?
Gout is caused by an overabundance or too much uric acid in a patient's bloodstream. Uric acid is a waste product, and so it's a breakdown product of purine metabolism, and we see that most commonly in red meats and organ meats and alcohol that we may take in, and shellfish. Those are the most common causes of dietary uric acid. Certain patients have a predisposition, or their genes actually predispose them to develop gout for other reasons, and that can be a problem with not taking in too much uric acid but not getting rid of enough of it. So you have the normal amount, but you start to build that up if you're not able to properly get rid of it. Either of those scenarios can result in a gout flare, and so the goal of treatment tends to be to keep you from having those flares by bringing your uric acid level down.
You mentioned genetics, so explain more for our viewers. What exactly is the genetics and who's at risk for developing gout? That's
a great question. So we think that there are different categories of gout, in that some patients tend to have gout that is more readily diagnosed through problems with their diet or problems with excretion of gout. There are certain patients who have genetic abnormalities that does not allow them to process uric acid the way that the rest of us do who don't have gout. Those patients tend to have a more common incidence of gout in families, and so if multiple members of a family have a genetic abnormality leading to their gout, then you'll see that more commonly distributed throughout the family. By and large, the most common cause of gout is that we're taking in too much uric acid in our diet, or taking in the right amount but not eliminating enough of it, and that may not be as clearly defined by who in your family has gout. By and large, the most common causes of gout, what I would say is that just because your parents had it or because your grandparents had it doesn't guarantee that you will have gout.
Is it more common in men or women?
It is, and that actually depends on the age of the patient affected with gout. Gout tends to be more common in patients after about their 5th decade of life or in their 40s. And after that, it tends to increase in the amount of gout incidence or the amount of people who we see with gout. We see typically about 3 million cases of gout per year, and that's mostly men, but as women approach menopause and some of those hormone shifts are in play, those numbers tend to balance out, and the number of men with gout tends to approximate that of women with gout.
So, given that there's so many types of arthritis that you see, how do you diagnose gout versus wear and tear osteoarthritis or rheumatoid arthritis?
It's a good question, actually a moving target kind of question. The most direct way to diagnose gout has been and remains to this day taking actual uric acid crystals out of an affected joint. We call that an arthrocentesis. So we'll take a needle and try to actually pull some fluid out of the joint that's inflamed and hot and red and try to demonstrate that there are crystals in that. So it's a straightforward process. It's a tried and true process. It's an uncomfortable process for patients, especially if you have a joint that's already red and painful. If you walk into my office and I mention to you I want to put a needle into that joint, patients don't necessarily think that that's something that they want to undergo. We do have more newer modalities in terms of diagnosis of gout. We've been using ultrasound more commonly, so we can look for evidence of uric acid being deposited onto the surface of tissues, and that's one way we can use that. We can use ultrasound to diagnose gout. Another way is looking for characteristic erosions or damage to the surface of the bony structures that those crystals can cause if they're in place for a long time. One of the newer modalities that we've been using is called dual energy CT scanning, and that's really a revolutionary product. It's very interesting to see. The images produced there are fascinating. They're great to watch. But what we're looking for there is actual 3D images of gout crystals being spilled on your bony structures or your surfaces, and looking for the damage associated with that there. Very straightforward, very little radiation in terms of relative exposure, and no needles. And so that makes it very, very easy. Now that technology is burgeoning and is being developed, but don't use it as commonly, but we do use it in patients where we're having a difficult time with diagnosis.
What are some of the trigger points you alluded to earlier in terms of what you advise patients to avoid?
Right. So there's some very common triggers for gout flares, and then there's some that are not so common and can be particular to individual patients. The things that you'll read about, things you'll see almost universally are shellfish are a huge trigger for gout flares. Alcohol is a very well-known trigger for gout. Red meats or organ meats can certainly cause gout flares, and then foods that are high in high fructose corn syrup, so starchy cereals and sugary sodas and the like, can definitely cause flares of gout. Interestingly enough, there are medicines that we use commonly that can also be associated with flares of gout. So commonly, diuretics can cause you to not only hold on to too much uric acid, but can raise your uric acid level in and of itself. And then it can also cause shifts in your body fluid that can predispose you to gout flares as well.
And by diuretics, you mean what?
Water pills or fluid pills, we commonly call them.
All right. So if somebody has gout and you tell them to avoid these triggering foods in the diet,
right.
What medicines potentially will you prescribe?
Yep. So several different agents that we can use. The treatment of gout is actually multi-tiered. So there is the management of the acute problem, which is why the patient comes to see you for pain and swelling and redness. So anti-inflammatories are great for that. There's a well-known drug named colchicine that's good for managing gout as well. Some of the anti-inflammatories we might use might be naproxen or indomethacin. These are well-known, tried and true drugs. The second aspect of managing gout is getting that uric acid level down. So once we've controlled the pain and inflammation, how do we keep that from coming back? And that's a separate category of drugs, and those are urate lowering agents. And there's several. Allopurinol is a common medicine that we use. It's another medicine called lesinurad, which is relatively new. There are some newer agents that we use that can actually be given by IV infusion for patients with severe gout that's been not responsive to other standard therapies. Cristexa or pegloticase is a newer medicine that we're using for management of gout.
If things don't get better, if they don't respond, what is your plan B?
It's a great question. So we tend to stratify patients by those who have their initial flare of gout and who have not been exposed to treatment, and versus those who have been seeing lots of different treatments and haven't gotten better. By and large, patients who we find early with gout, we do a pretty good job treating these days. So medications like the allopurinol that we mentioned are good at bringing your uric acid down lower. In those patients who have problems with that medication or other medications similar to it, we will think about using more medications that are given through IV infusion that tend to be a bit more effective. Side effect profile is significantly different between those agents, and so there's a good process of consideration that goes into determining who should get which medications. But if they're patients who are not responding to first-line therapies, we've now more recently had second-line therapies that can be helpful in treating those patients as well.
You mentioned side effects.
Right.
Let's target, for example, colchicine,
right,
which you mentioned is a time-honored remedy for gout.
Right.
What are some of the side effects of colchicine?
Colchicine is a relatively well-tolerated drug. The most common complaint that we hear is abdominal pain and diarrhea. That we tend to see less of. Our management of gout with colchicine has changed somewhat over the past several years, and so we're able to treat gout effectively using less of it. By and large, the more colchicine you use, the more you'll see incidents of diarrhea, abdominal pain, and cramping. There's some other side effects that we see less commonly, so things like suppression of your bone marrow or the part of your body that produces your blood cells, and also problems with your liver can be seen as well. And we monitor patients for those on a regular basis.
See, I'm a gastroenterologist. You knew I'd pull you into the GI part of the discussion.
I knew it was coming.
Share with our viewers some of the potential presentations of gout outside the joints. Where else can there be issues?
That's actually a fascinating question, and it's a very, very part of what draws most rheumatologists, I think, to gout. The treatment of straightforward gout is wonderful because you can have patients come in and provide immediate relief. But some of the things that you're privileged to see in terms of seeing gout that deposits in tissues and gout that can cause problems with patients with renal failure and incidents of gout attacks leading to worsening cardiovascular disease and cerebrovascular disease, or strokes, I should say. Being able to make inroads with those patients is a wonderful thing to see. So you're not just treating that acute pain, but you're treating possible side effects or possible associated conditions that could arise if the gout's not taken care of. So that's a very rewarding part of treating gout. So
give some examples of gout presentations outside the joints. Where have you treated some of the, or seen some of the unusual presentations?
Most fascinating case that I saw was a patient who had a deposit of gout in his eyeball and would actually have pulsing, painful redness at that area whenever he had a flare of gout in his joints. During my training, I actually had the opportunity to meet a patient who had gout in his chest wall, so here in his sternoclavicular joint, and thought he was having a heart attack. And come to find out, we gave him some colchicine. He felt much better pretty quickly. It can present in any joint in the body and can deposit in any tissue in the body. And so the presentations are varied. And so you probably mentioned some stories to you from some of my colleagues. But those are two of mine that I think would stand out the most.
Right. How about the kidneys? Have you seen any issues with that?
We have. So kidney stones can be associated with elevated levels of uric acid and uncontrolled gout, and that is also an indication for treatment. So not everybody who has a high uric acid level needs to be treated for that, but patients who have flares of gout that happen over and over again, or patients who have kidney stones because of their uric acid, are certainly those that we actually offer treatment and try to get their uric acid level lower.
Terrific. Dr. Potter, we're out of time. If our viewers have any questions about gout, how can they reach you?
The best way to get in touch is through the practice of Arthritis and Rheumatism Associates. Our website is www.washingtonarthritis.com. Phone number is 301-942-7600.
Thank you for joining us on Housecall.
Absolutely. Thanks for having me. Appreciate it.
My thanks to Dr. Ahn and Dr. Potter for joining us for this evening's Housecall. Thanks to my terrific team here at the studio, and thanks to you, the viewer, for making Housecall the success it has become. Let us know how we're doing. You can reach me at my practice website, montgomerygastro.com. As for our next show, it's going to be focusing on a public health service here in Montgomery County, the Latin Health Initiative. It's going to be a fascinating program. See you then next time for another edition of Housecall. Good evening.